talk about a very, very interesting case, which is a common presentation to a pediatrician as well as to a pediatric endocrinologist with a lot of implications in terms of the immediate diagnosis, assessment, and long-term management. So delayed puberty, as we have discussed earlier, also is a common presentation in boys. It is much more common in boys, but it is more likely to be physiological as compared to girls. So just to highlight and touch base on this scenario, we start off with two cases which highlight why we need to be cautious in evaluating these boys. So this was a 13.5-year-old boy who presented with delayed puberty. Testicular volume was 3 ml and pubic hair was 1. Was being evaluated by a physician who found that the height was also less and did evaluation which showed a low LH and a test 2 was undetectable. So somebody who is below 14 years of age, of course, if you do the workup, you will say that this is hypogonadotropic hypogonadism. So this is a physiological hypogonadotropic hypogonadism. Unnecessary workup was being done, unnecessary confusions advising MRI, which was clearly not required. On the other hand, we have the 16-year-old boy who presented with pubertal concern, onset at 13 years of age, stopped for 2 years, had a testicular volume of 3 ml which was soft, and stage 3 pubic hair development, was reasonably tall for the family and was labeled as CDGP. Now this is the other extreme. So what we are seeing here is a boy who had stalled puberty, who has pubic hair development, has a smallish testicular volume which is soft and also is not short and still being labeled as CDGP, while we need to be worried. And when we talk about red flag, we'll talk about these concerns here, and this turned out to be a large intracranial lesion. So on one hand, we are unnecessarily messing up with those cases, doing unnecessary workup, causing confusion. And on the other, we are not working up when it's required. So this balance is required. As I said, 5% of all boys will have delayed puberty. Large number of them will be physiological. The key would be to identify these 30% while not missing these physiological causes. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of resources with regards to pediatric endocrinology, including a lot of validated tools, fellowship programs. We do run regular grand rounds like these along with postgraduate lecture series every month, which you can have a look there. Our publications are available both on the print version as well as the Kindle version, the basic, the protocol, and the advanced ones. And our mobile application allows clinical evaluation interpretation with minimal inputs. The grand round today would be about a boy who presented to us with delayed puberty and short stature, a very common presentation to the pediatric endocrinology clinic. And to present that, I will be joined with by Dr. Alapan, our fellow. So Dr. Alapan, over to you.
Thank you, sir. Good afternoon, everyone. I am Dr. Alapan, fellow in pediatric endocrinology in Regency CDF. So I am present with a case of delayed puberty. A 17-year-old boy presented to us with lack of development of the secondary sexual characteristics. He has also noticed that there are enlargement of both breasts for the last 3 years, and he is not gaining height in comparison to his peers for the last 4 years.
So if you hold on there, so you have a boy who has no secondary sexual characteristic at 17 years. So is this physiological? Is it normal or abnormal?
Sir, after 14 years, if he is not developing any secondary sexual characteristics, so we can take it as a delayed one.
And the second point is also very important. You talked about lack of significant breast development. So what does it imply? What conditions will cause breast development along with the delayed puberty?
So the conditions which are implied in breast development along with delayed puberty are hypogonadotropic hypogonadisms or hypergonadotropic hypogonadisms. And the differential main to this is self-limited delayed puberty, which will not have any gynecomastia in that.
So the presence of gynecomastia is a sign which goes against a self-limited form of delayed puberty. So, Dr. Sandeep, what are the other signs in this scenario that you say are against the self-limited form of delayed puberty in this? So one, of course, we said that gynecomastia goes against it. Second, even on the history. So what you're trying to do is right from history, you try to make the diagnosis. So there are two things. You said that age is a bit already advanced. So 17, 18 is considered to be a cutoff point. Second, yes, so this is a very specific point which you need to dwell it. whether he was always short and he was now not growing that much, or he was growing well and he has stopped growing. Because that will give an important clue again from that regard. So even your first three complaints are making us towards at least one direction. Yeah.
So when we talk about delayed puberty, the major basic four questions that came in our mind, whether it is really a delayed puberty, whether it is setting up with the definition of delayed puberty. If it is a delayed puberty, whether it is a physiological one versus a pathological one. If it is a pathological one, what is the site, whether it is due to the any gonadal problem or any axis defect in the HPG axis. And next question, what is the etiology of this delayed puberty in this child? So moving on to that, whether our boy is fitting into the definition of delayed puberty, this is a guidelines that has been published in 2022 and ENDO-ERN guidelines. It said a already known phenomenon that we know that if even at the age of 14 years, if there is no development of puberty or the puberty's SD score is less than -2, or there is any failure to show adequate progression of puberty, we can call it a delayed puberty. So based on this definition, we can call our boy as a case of a delayed puberty. There are some puberty nomograms that are present on the Caucasian population. This puberty nomogram will help us to decide about the puberty SD score, and it is based on a Danish population of 451 children. So
hold on, this is very important. So basically, this is important because sometimes people will come to you for the first time at 17 years. Now, you cannot just say, okay, 17 years, testicular volume of 4 ml is normal. So this you need to be very careful about. So something which is, let's say, if you use one criteria, that if the TV is more than 4 ml, we consider it to be pubertal. But that 4 ml may not be normal for somebody who is 17, 18, 19. Similarly, pubic hair too may be normal for 14 years, may not be normal for 18 years. So if you look at those nomograms, they are very nicely put. You say genital scoring SD, pubic hair SD and TV SD. And what you are basically trying to do is that you're looking at the age and where the SD becomes significant. So can you tell me from this figure what TV will be significant at 17 years? This child is 17 years.
So in the 17 years of age, if anything below 8 ml of testicular volume, we should consider it as a defect in the pubertal progression.
So SD score is, you are saying, is
-2, less than -2.
-2. Good. So this is a very important point. So this is something which we often get confused. So we say, okay, 4 ml. Everybody we say 4 ml. No, for somebody who is 17, this child 4 ml is not normal. He should be 8 ml, as you said. And he should have a pubic hair stage of, again,
pubic hair stage of
pubic hair 2 at least. At least 2.
Huh?
And genital score, of course, again, you are saying is something like he should be G2 to G3. So very important, this is a very important thing which we should incorporate in our clinical practice, is rather than using just a blanket statement, you try to correct it for the age. Of course, this is population dependent and everything, but ultimately we are also using Western figures when we say 14 years and they seem to be working fine. Yes, so this was a good point to put in. Carry forward.
So moving on to the history of present illness. So patient complained about lack of development of the secondary sexual characters in terms of the development of beard, mustache, and he has complained that he has sparse development of the pubic hair, even if he is 17 years old. There is bilateral increase in the breast in the last 3 years, and he again complained about the decrease in the linear growth, which he noticed around 12 years of age for the last 4 years or 5 years in comparison to his peers.
So you need to be more clear about this. So when you say he is gaining less as compared to the other members of the peers, is he growing absolutely not growing, or is he growing slowly?
He complained about, sir, that growth is not that significant as it was.
So of course, during puberty, we expect the boys to go around how much?
20 to 25 centimeter.
In 1 year, the growth velocity.
8 to 10 centimeter will be.
So peak will be around 12 centimeters, maybe 8 to 10 centimeters. So if you're comparing with that, he's gaining 4 to 6, then he is not bad. But if he was going very well and is now going pathological, below 4, that will become significant because that could be an acquired cause of delayed puberty. Yeah.
So moving on to the history of present illness, there is no history of, I've taken the negative history, there is no history of any anosmia or family history of anosmia, as in Kalman syndrome, no history of any synkinesia, seizure, skeletal defects or hearing defects as in seen in other congenital form of hypogonadotropic hypogonadism. There is no history of any delayed saving in father or delayed appearance of the secondary sexual character in father, also menarche delay in mother. There is no history of any headache, visual disturbances, diplopia, as indicated, as seen in cases of pediatric brain tumors. No history of any trauma, tumor, infection, radiation in the head. There is the patient complains there is no pubertal onset. There is no history of any pubertal onset followed by the lack of progression. And
so this is very important. So when you say there is a pubertal onset and lack of progression, what does it exclude? Yes. So if somebody was very sick, that's why his puberty was not happening, then it should start and it should continue to start. If there is self-limited form, it should not start and then start. So this is a very important point, which is not excluding CDGP. But it does not mean that this is CDGP. So many conditions, you can have no puberty at all. So when you compare hypergonadotropic hypogonadism versus hypogonadotropic hypogonadism, who has stalled puberty as a major manifestation?
Hypergonadotropic hypogonadism, sir.
Yes. So this point may, quote unquote, I'm talking about Klinefelter, if I be very frank, makes Klinefelter a less likely possibility from that perspective.
There is no history of any increased pigmentation, any salt craving, or any headache, dizziness, vertigo, visual disturbances present in the children. There is also no history of any increased weight gain, easy visibility, stria, difficulty from standing up or combing his hair. No history of any pain, abdomen, diarrhea, pica, or preference to rice, as we can see in the celiac disease. No history of any dry skin, constipation, weakness, and lethargy, as we've seen in the hypothyroidism. And no history of polyuria, polydipsia, and recurrent fractures, as we've seen in cases of RTO. Regarding the past illness, there is no history of similar illness in the maternal uncles or cousins in the of the patient, and there is no history of any hospital admin.
So why you ask specifically for the maternal uncles?
Because there are some congenital form of hypogonadotropic hypogonadisms like ANOS1 defect, which is X-linked, and that is why they are present in the maternal side.
Yep.
There is no history of any hospital illness, admission due to any systemic illness, no history of any treatment due to malignancy, or any history of repeated blood transfusion, as we can see in cases of thalassemia. There is no history of mumps in the childhood, any fever with vesicular rash, chill, and rigor also.
So when you say mumps, what is the effect of mumps on the testicular functions?
So mumps usually causes mumps orchitis,
Yeah.
And the orchitis mainly, actually, there are two mechanisms where how orchitis happens. Number one, there is direct infiltration of the virus, and it causes damage to the seminiferous tubules and the other structures. And number two, when there is a viral infiltration, the tunica albuginea actually forms a cover around the testis. So there is a pressure effect which also causes the testicular atrophy. But basically, it is usually seen as a case of seminiferous tubule defect, which further.
So this is something you need to remember, that it is more of a patchy orchitis. And you need much less amount of Leydig cell function to produce testosterone than the germ cell function to produce sperms. So most of these acquired causes, whether you talk about radiotherapy, whether you talk about chemotherapy, whether you talk about mumps, they do not classically present as testosterone deficiency. Their predominant presentation will be like infertility. Yes. So this is something which you need to be cautious about that. Yeah.
So, and there is also no history of any testicular pain, trauma to the testis, or the testicular swelling, redness also present. So moving on to the family history, there is no similar history of delayed puberty, as I've already explained in the maternal side, no history of delayed puberty in parents, and no history of any consanguinity between the parents present. Regarding the birth and antenatal history, antenatal event was uneventful. Mother doesn't take any medications or any have history of any fever or rashes. There is no history of any oligo or polyhydramnios, less fetal movement. Baby was term 3.1 kg. There is no history of any breech presentation or forceps application during delivery. No history of any hypoglycemia, seizure, midline defect, or cardiac defect present during neonatal period, or no history of any hospital or NICU admission during the neonatal period. But drug history, there is no significant drug history the patient has given, and the personal history is completely normal. Moving to the nutritional history, the patient complains about adequate nutritional intake, which I calculated almost around 1600 kilocalorie. And there is no history that's suggestive of any eating disorder that is present in this patient. Socioeconomic status was lower socioeconomic status with no emotional issues in the family present. So based on the history, we have major 4 differential diagnoses in our right now. that one is self-limited delayed puberty or CDGP, that and number 2 is hypogonadotropic hypogonadism, hypergonadotropic hypogonadism, and multiple pituitary hormone deficiency.
So out of these, which one is more likely from your perspective?
If we just go by the history, we can say this more looks like a hypogonadotropic hypogonadism rather than self-limited.
Why not MPHD?
MPHD would have other manifestations like pigmentation increase or lethargy, weakness, or cravings.
Pigmentation?
There is cortisol deficiencies, feature of cortisol deficiency.
You have to classify. So MPHD could be congenital, which is very unlikely. Then he'll be short, very short and everything. But you cannot rule out acquired MPHD, which is a major cause of concern. It's just like the second case. If you remember, I showed 16-year-old boy who was fine. Now the height is okay, but not growing. Then delayed puberty, then cranium. So you cannot rule out acquired MPHD because that is something which you will need to be worried about. So CDGP also can you exclude based upon your this thing?
Not really, but the age is one thing that is
Age
the
is
gynecomastia. Both
so
the things are
gynecomastia,
going
of course,
against.
if you confirm that there is a clear-cut gynecomastia
And
and
the
not
child is not that
hypomastia.
obese also. So,
So that becomes it's there. You cannot exclude that. Hypergonadotropic hypogonadism. If you say Klinefelter syndrome, I would be a bit wary about that. And generally, that's the most common cause that we see. So yes, I agree. HH will be number 1. CDGP, because of its prevalence, will of course be number 2 based upon this. And MPHD you have to consider in this based upon history only. So once you know in the history, then you can go on the examination specifically. Yeah. So Dr. Vibha, what things based upon this history you like to look on the examination? Maybe you can ask Alapan what things you like to look at first. So any specific pointers? These things you want first.
So I would like to, if the child present like this and giving a history like this, first thing I would like to see the general examination. General examination, we should look for the anthropometry first. So the height, what is the height parameter, what is BMI in these children. Then we have to go for the any pallor cyanosis clubbing, though that is present usually in nutritional.
So that you will of course do. I'm asking about specific pointers you want to tell. 3-4 things that.
So based on that, SMR staging, testicular volume, pubic hair, gynecomastia present.
So pubic hair becomes very important. Gynecomastia, as you said. Then
testicular volume, the size of testis, what is that? And the anthropometry is very important. Will be
yes. So these 4 will give you the clue. Yes, and so gynecomastia becomes important. So these 4 things will give you the mind. So others are relevant, but if you tell me about the height, testicular volume, gynecomastia, Dr. Vibha said, and pubic hair, most of our diagnosis will be sorted out. So carry on.
So if we compare a table and see the history presentation, the 4 things that we take from the history is one is delayed puberty, number 2 is gynecomastia, the short stature, and the pubic hair. We can see delayed puberty will be present in all cases of in our differential diagnosis, while the gynecomastia will be absent in cases of CDGP and MPHD. Also, the pubic hair will not be present in cases of CDGP and MPHD.
So when you are saying gynecomastia is much more in hyper-hypo as per your this thing, why is that?
Yes. So in hyper-hypo, what happens actually, there is elevated level of LH. So that elevated level of LH causes inhibition of the 17-hydroxylase enzyme. So the androgen conversion is not there. And secondly, there is increased aromatization of the aromatase activity.
So basically, there is a disrupted steroidogenesis in the testis causing more. What causes gynecomastia and hypo-hypo? There is no LH. So he said that LH is the major factor causing gynecomastia in hyper-hypo, but hypo-hypo you don't have any LH at all. So yes, so yes, so for the same amount of androgenic activity, adrenal androgens are more estrogenic. So that is why you have a adrenarche gonadarche disconnect, which causes that from that. Now again, you have mentioned that MPHD you will not have gynecomastia. But if it is an acquired MPHD, it may happen. So we have to be a bit cautious.
Even sir, pubic hair could be present in.
Yes, so that's So if it's acquired, and when you say MPHD, it could also be growth hormone and GnRH alone. That could also be there. So yes, when you talk about what you're talking about is pure congenital MPHD, they will be very short. They will have no gynecomastia. They will have no pubic hair. Pubic hair, I would say, is the very, very important thing when you look at in a boy with delayed puberty. As you have very nicely said, that pubic hair presence will basically go very much against self-limited delayed puberty as well as a proper MPHD, so to speak. Yeah, carry on.
So moving forward onto the general examination. In general examination, the facies was normal. It is not a immature facies. The patient having a stable vitals and there is no history of any, no presence of any pallor, cyanosis, clubbing, edema, jaundice, as we can see in the systemic illnesses. Everything else is normal. But
So why is blood pressure important?
Blood pressure important because there are some steroidogenic defects that can cause a high elevated blood pressure. Tiny filter can also present some.
So which steroidogenic defect will cause delayed puberty and high blood pressure?
In male.
Yes. It's a male only, no?
It will be
17 hydroxylase, but it is not expected to present to you like a.
It will be sexual infertility.
It will be more like a DSD. It will be more like a DSD, look more like a female appearance. So hypertension is much more important in girls with delayed puberty. Why? Which condition? 17 hydroxylase, of course, can be the cause. Turner syndrome.
Turner.
One thing which I have picked out on hypertension is renal disease. So if somebody has a chronic disease, then renal disease, you will have hypertension. Yeah.
Even sir, some congenital form of HH are also present with renal anomalies. There,
yes,
it can be a presentation like a hypertension.
So you have to be cautious from there. Yeah, carry on.
So moving on to the SMR sexual maturity rating staging, the testicular volume was 2 ml bilateral, which is less than 2 standard deviation score, and SPL was also 4 centimeter, which is also less than 2 standard deviation score for his age. So if we go by only the testicular volume, here we can see that the delayed puberty and the testicular volume, the hypothyroidism part is ruled out because the patient doesn't have an enlarged testis. But the other features like GnRH deficiency versus Klinefelter in hypergonadotropic hypogonadism or constitutional delay, we can't rule out on the basis of only.
How much for the TV you said?
2 ml, sir.
2 ml. 2 ml. So 2 ml is an ambiguous thing.
Yes.
If it's more than 3 ml or more, I would keep pure GnRH deficiency less likely. Klinefelter, depending upon when you're picking it up, it will depend on that. Yes, carry on.
So if we combine with testicular volume and the pubic hair, then we can certainly say that in GnRH deficiency, the testicular volume will be very small, especially the congenital forms, along with the presence of the pubic hair. In cases of CDGP or systemic illness, the testicular volume will be prepubertal, but not as small as we can see in the congenital GnRH deficiency, as well as there is no presence of any pubic hair. Hypothyroidism will be a larger testis with no pubic hair, while in obesity, the testicular will be prepubertal, but there will be presence of the pubic hair. In MPHD also, the testicular volume will be smaller and there should be, there may not be presence of the variable presentation of pubic hair.
So what causes delayed puberty in obesity?
So in obesity, there is increased fat mass in our body. So it increases the estrogen level in our body. That estrogen inhibits the gonadotropin levels, causing the delayed puberty.
And adrenals are working. So that's why you have pubarchy. And in hypothyroidism?
In hypothyroidism, delayed puberty, it is actually due to the FSH effect on the testicular volume, causing the enlarged testis. And there is bone age is delayed, so the pubic hair will be. And it will inhibit the GnRH secretion as well.
Which will prolactin.
Prolactin.
So high prolactin will suppress the GnRH. So it's just the mirror image of von Wieck-Grumbach syndrome. See, Sertoli cells are what? They are like follicles. So Sertoli cells are bigger. Leydig cells are not working. So that's the pretty much scenario. Yeah.
So
if you go back just 1 second. So if you look at the first scenario of GnRH deficiency, your testis is not working, adrenal is working.
Yes.
If you go to the second scenario, neither the testis nor the adrenal are working. In this scenario, you have got Sertoli cell working, Leydig cell not working. Here the adrenal is working and the testis is not working. So if you just put this 2 into 2 table maybe next time, that will give you testis, adrenal, you will get which way the problem is. Yeah.
So moving on to the anthropometry part, the height was less than 3rd centile according to the IAP 2015 chart. Weight was between 10 to 25 and the child is not obese, less than 23rd adult equivalent.
And when you say obesity and delayed puberty, what level of obesity are you talking about?
It should be ideally severe obesity.
So it's not a mild one. So obesity in girls causes early breast development and a disjuncted puberty. Obesity in boys, very severe obesity in boys and men also will cause hypo.
And also, sir, there are syndromes like Prader-Willi and Bardet-Biedl where obesity also associated with hypogonadism. And in head-to-toe examination, there is no finger abnormality present in the children, no extra finger or syndactyly was present. Gynecomastia was 5 centimeter bilateral, symmetrical, firm with tenderness present, and there is no appearance of any sexual secondary characteristics that was present.
How was the appearance? Was there any unicoid appearance?
No, sir, it was not unicoid appearance in the children.
So this is important to mention. And one thing you did not mention in anthropometry, two things. What was the arm span? So arm span, upper segment, lower segment, yes. They will all be very relevant from there because you can exclude Klinefelter from here. Okay, so what do you see on the chart? The height is much below the chart and weight is reasonable. What is the SDS?
SDS is height is minus 2.81 SDS, weight is 1.03 SDS, or BMI is 0.3 SDS.
So he is significantly short.
Yes.
And he is that. Now, if you combine this picture, you have a short child with delayed puberty, with pubic hair which is there, and there is gynecomastia. What are you thinking of?
So it basically rules out CDGP because in a short child with gynecomastia presence and delayed puberty, so rather there is two differential could be there. One is acquired MPHD versus a hypogonadotropic hypogonadism.
Which is more likely?
MPHD will be more likely.
When you see somebody with Kalaman syndrome, do you think this is the feature of Kalaman syndrome? Sure. So they have a normal development. They don't have a pubertal spurt. But this child is not just pubertal spurt. He is not growing also. So it is something more. Or what's the familial expectation?
Familial is 167, sir.
167. So he's short for the family also. So clearly, although you can say, okay, this may look like a slightly delayed, but definitely it is much more than that perspective. So Kalaman, isolated HH, I would be a bit cautious about in this scenario. Yeah.
Moving on to the systemic examination. Systemic examination, including the CNS examination, was normal in this child. There is no history of any defect in the smell sensation or any focal neurodeficits that is present in this children. So before moving further into the investigation part, let's see what the hormonal levels in our body during a normal course. So there are two major peaks that is usually happen in our body with LH, FSH and testosterone will be higher. One during the 0 to 6 months, that is known as also mini puberty, and other is during the pubertal age. Two other important parameters were AMH and inhibin B, which tells us about the testicular function. AMH is throughout the childhood, it will be elevated, while inhibin B is a better parameter for the onset of the puberty. It rises just behind the testosterone level, and in puberty, it will be on the higher side.
So inhibin B is like a precursor of testosterone, and AMH is not good. So AMH is not good for pubertal onset. It's only good mainly for testicular function in early infancy. This is very good graph that you are showing here. So how many months does inhibin B precede testosterone rise?
3 to 4 months.
6 to 12 months, I would say. So you get that 6 month idea. So it's like you're looking through that crystal ball, how much time is left. So if your inhibin is also very low, you will take a long time. So if you look at the sequence of events, if I talk about rise in inhibin, rise in LH, FSH, and then rise in testosterone, what do you think is the chronological sequence? What happens first, second, third, fourth? No, but how will inhibin come?
They release
So FSH. FSH is of course there. Inhibin is coming through FSH. So FSH is anyway not low. FSH is reasonable. And then you have got the LH, nighttime pulses of LH. Then you will have inhibin B, then testosterone. I've seen many cases in which LH is reasonable, 2 or something, but testo is 0. And when you follow them up after 6 months, the testo will start coming from there. What will be the time when testo will be high? Which time of the day? First time you will be able to pick up.
It should be morning.
Why?
Because the gonadotropins are high in the...
So the pulses, the first change of puberty is the LH pulses at night time. So that's why your testo in the morning is the first clue. So if you look at these graphs, you will be able to know the reason why we are using inhibin B.
So moving on to the investigation, the routine workup was normal in this child, and there is.
Just hold on. So
yes,
bone age was 14 years.
Yes, sir.
Was he normal for for his bone age?
His height as well?
Yes, his height was normal for bone age or not?
No, sir, height was not normal.
But not that abnormal.
No, height age is around 12 years.
So he is within the range. So what does it tell you? So he is short, but he is mainly short because his bones are delayed.
Bones are delayed, okay.
And then if you club that familial, if you basically get your corrected high standard deviation score for bone age, you will know that if you correct it for bone age and you correct it for the family, maybe he is absolutely normal.
Yes.
So when you are saying short stature, you need to really look at whether he is short for the family and whether he is short for the bone age and whether he is short for both. So he is probably not that short. So that component of short stature, which was taking us towards MPHD, becomes a bit less likely in that regard. So that bone age is also the most. So before we go ahead, so what are the most important investigations? Of course, bone age will be the one. Systemic, of course, we want to exclude that. And then we discussed about the role of inhibin B, LH, FSH, testosterone, and further. Carry on.
So moving on to the hormonal workup, we have found that the LH and FSH level were quite low at the 17 years of age, with testosterone was undetectable almost. We have got an inhibin B baseline level, which is almost around 50. So
how do you interpret that inhibin B level?
So basically, if I go by our algorithm, if the testicular volume is 2 ml and the inhibin B is 53, we should ideally go for a stimulation test. That is,
so we are in between. So, or you wait for one. So it can be both.
Yes.
But it is favoring. Now that algorithm is predominantly for anybody who is 14 and above. But he is 17. So this 17 also you have to give that weightage. So if you give weightage to 17, it goes more in favor of a HH scenario. Yeah, carry on. So with no testosterone, inhibin B, which is not very high, this is going in that favor. Yeah.
So this there is a paper that published from PGI Chandigarh in 2021. They have seen that the role of inhibin B. There are a role of inhibin B in both basal as well as stimulated as well as delta change in the inhibin B. They have given a cutoff of basal inhibin B of less than 50 and of having a specificity of 100% for diagnosis of the hypogonadotropic hypogonadism. While the level more than 97 or more than 100 is having a 100% specificity of marking the onset of the puberty.
So this is the basal level.
Basal level, yes.
So if your inhibin B is 100%, so CDGP can never have less than 50. That's what you're trying to say.
They are
okay, going to this study, less than 50 is basically against CDGP. Of course, it will depend upon what stage of CDGP you are picking up. At 17, if it was less than 50, I would be very, very cautious. And 53 is not a big number. Yes. So it is go more in favor of a permanent HH in that regards. Yeah, carry on.
They had also given a novel marker, that is a FSH stimulated inhibin B, and given they had made a ROC curve where they had shown that inhibin B stimulated level, if it is more than 116, having 100% sensitivity and specificity to denote the onset of the puberty. So first of all, before we go into all that, why do you want to differentiate CDGP versus HH? Anyway, testosterone is to be given to both of them. Yes, because if it is a case of HH, there are issues of fertilities in the future. No, now. Right now. Yeah. Because the treatment protocol will be different in both cases of HH and CDGP.
How?
One. And
how?
In CDGP, we used to give testosterone injections 3 or 4, and then we stop, see for the pivotal progression whether it is happening or not. But in cases of HH, we have to give a long-term testosterone. So suppose you stop after 3 months, what harm it is? If it is HH, it will not respond, then you continue. The major difference is that you need to understand that some people are very concerned that if you expose these testes to testosterone, that can impair their fertility chances. So if you want to decide right away from the beginning, I want to give this fellow gonadotropin therapy for induction, then knowing the two becomes important. This is a theoretical concern, but that is the main reason. Otherwise, why are you that much bothered? Why are you doing these sort of fancy tests or doing FSH inhibin B? You can give a course for 3 months, wait for some time, not responding, that's permanent HH.
So that will be the classical scenario. But why people are doing is more in favor of these parameters. Yeah.
So moving on to the the pointers. Right now we have that age is more than 17 years, which points against the CDGP. Also, the height is less in this child, minus 2.51 standard deviation score, which point in favor of MPHD and CDGP rather than hypogonadotropic hypogonadism. The other parameters like testicular volume and pubic hair and gynecomastia are also pointing towards the favor of hypogonadotropic hypogonadism. But the micropenis and the age, which are both against the CDGP, while the low
And when you are saying micropenis, it was 5 centimeters.
4 centimeters.
4 centimeters. So, of course, that you have to think of so many other things. So, what has happened in this case is that he did not get any pubertal growth. So, you cannot use the 17-year cutoff for him because he had no exposure. So, of course, so if you label him like a true micropenis, when you are saying HH, the micropenis is like 1.7, 1.92 centimeters. So that is something which is important. So I would not just based upon SPL of 4 say it cannot be CDGP. This is something to remember because he has no testosterone exposure. So many people will be lying around that mark. But if it was 2.53, that will be for sure.
But sir, it will rule out the CDGP.
It will not rule out. I won't call it like a proper micropenis because why are you comparing him to a 17-year-old? When you look at, suppose his bone density, you do a bone density, will you compare that bone density to 17 years?
No.
Because he didn't get any.
14 years, even if the bone age is 14 years, at the 14 years, the 4 centimeter will be also less. More
but this is not going to exclude CDGP completely. This is something you need to understand the nuances of it. Otherwise, you will say this is not CDGP just because of that. There are many other reasons. But this micropenis, I'll be very careful about labeling these 4 centimeters, and that's why you don't use penile size as a criteria when you're really evaluating for that. And he did not come to you with micropenis.
No, he came to us with delayed
other features.
Yes.
Yeah.
So if we go by our algorithm till now, if the gonadotropin levels are low, we should look for the testicular volume, which is a less than 1 ml, and the inhibin level, basal inhibin level is less than 50. It goes in favor of permanent HH. While the testicular level more than 3, I would say rather 1 ml. If inhibin level is more than 100, it goes in more favor of CDGP. While in between, if the testicular volume is less than 1 with inhibin B level more than 50, or more than 1 ml of testicular volume with inhibin B less than 100, we should go for a stimulation test like GnRH stimulated LH or FSH stimulated inhibin B level. If levels are higher, then
so how did they do the FSH? How much dose was given?
Sir, they have given in both boys and girls, both. So in girls, they have given a lower dose, 150 international unit on day 1, 2, and 3. And they had checked for the inhibin level on day 24 hours after the day 3, on day 4. In boys, they have given 300 international unit and given on alternate day. I don't know why the reason, but
you give gonadotropin alternate day because if you give daily, it will be desensitized. So alternate day for
that is
female is a different mechanism. So for how much time?
For 3 doses only.
Because if you talk about female production of inhibin B, it has to come from the follicle. Follicle has to grow. It is going to take time. Okay. While boys already the Sertoli cells is there, so you give alternate day. And what is the cost of FSH?
They didn't mention what.
So they didn't mention. You should check it now. So when you're talking about whether you want to alter your practice or not, that will be the question here. So first of all, this is how many other studies are there?
I have not found much study. I have not searched about it.
So this is an interesting way of diagnosing it. We have now accepted inhibin B as a prime marker. We don't do a HCG stimulation test. We rarely do a GnRH stimulation test, but GnRH we are keeping a bit lower down. So your question would be whether at that point of time in somebody who is 50 to 100, whether you do a FSH stimulated inhibin B versus a GnRH test, you need to have a head-to-head comparison.
They had also done some GnRH, but they found that the sensitivity specificity in cases of FSH stimulated inhibin B is much higher in comparison to the. But the study population is very less, like 26 child was there in the population.
So this is an interesting concept which needs to be further evaluated. But it is logical. See, when you're looking at GNR stimulated versus this is going to happen a bit earlier. Now, why do children with CDGP respond to GnRH while HH do not?
Because in CDGP they have a electrical and puberty exposure to GNL.
So they are priorly sensitized to the effect. So this is something which is there. So key messages there are that of course when you do a basal test, you do a LH, testosterone and FSH, that's part of the workup. If your testosterone is reasonably elevated, then you don't need to worry about that. If it's more than 20, many people say. LH more than 0.6. Of course, if that's 17, you expect the levels to be higher. Then you don't need to do a workup. If your LH is undetectable, if your testo is undetectable, then inhibin B. And in this case, if it's 53, I would be thinking more of a HH rather than that. So I won't be too much bothered about that. So I'll probably head towards the treatment arm. Because if you keep on investigating, then at the end of the day, the patient will run off also. So you have to worry about, think about that aspect. Because he's 17 years old, how long will you keep on doing evaluation? Carry on.
So based on these investigations, history and examination, we have a provisional diagnosis of 17-year-old male with delayed puberty or lack of sexual characteristics with short height and gynecomastia, probably due to the hypogonadotropic hypogonadism was the etiology.
No, this is hypogonadotropic hypogonadism. Now, whether it is reversible, irreversible, whatever, that's a different.
Yes.
But this is hypo.
Yes. So we plan for a
What further workup will you do?
from here. So we can look for the MRI to see.
So, do you need to do anterior pituitary function in this child?
In this child, we can do a anterior pituitary.
We should do.
We should do have.
Because clearly this child is short. And you have to think of other things because you rushing off with pubertal induction is not the answer. So you have to look at the cortisol at least.
The cortisol was normal, prolactin was normal.
And you have to look at the growth hormone plus minus. Thyroid would already have been done. And you have to think of MRI.
Yes.
So you have to mention that MRI was also done in
Yes,
this
sir,
case.
I mentioned it.
Okay. So don't show now. But this should have been shown later on that once you make a diagnosis, MRI should have been done as part of the workup. So clearly you have looked into anterior pituitary dysfunction is not there. There's no neuroimaging abnormality. And now you are sure this is a HH. Now the only question is whether you do a GNRS stimulation test or not, whether you do a FSH stimulated inhibin B or not. So my approach will be I'm pretty 99% sure. So better to go ahead in terms of the treatment because you say less than 50% is 100%. Less than 50 inhibin B is 100% specificity. So we had 52, 53 is nothing. You carry on.
So what are the treatment options right now available? That the pubertal induction in terms of the testosterone, and another thing we can do for pubertal induction is HMG and HCG given, which can also be used in the future for the fertility purpose. There is a guideline that is shown in the first in 2022. They show that both testosterone and HMG HCG could be used as for the pubertal induction. Now, what would be the ideal age? They have told that if any boy presented with which have a high risk of hypogonadism, they should undergo pubertal assessment at the age of 9 years. In high risk conditions, they have mentioned about like Klinefelter syndrome, probability of Klinefelter syndrome, probability of mixed gonadal dysgenesis, partial gonadal dysgenesis, or any androgen insensitivity like condition. But if a boy having a diagnosis and with a high risk of hypogonadism, they have recommended for pubertal induction started at least by 12 years of age if there is no pubertal development.
So don't delay till 14 years if you are sure that this is permanent HH. So this could be something else that you have to be. But then how do you make a diagnosis of permanent HH at 12 years?
Sir, risks we have to assess.
Like what?
Whether the child having a high risk, that if the child has a anosmia, if a child is very short for
most of these will be those who come to you with micropenis. So
And
infancy, they will come to you with micropenis. Then the other would be like, as you said, other signs, strong family history, somebody with septo-optic dysplasia, somebody with a known CNS problem, somebody who has a tumor, which is surgery has been done. So all those things can explain that. Yes. So if you have tall child and who has got a large, long leg, so short stature is a predisposes even before it happens, before the other features, so that you can pick it up. So this will be rare. All our cases who come to us with delayed puberty are coming much later. So this question is a bit difficult, but yes, if you know, Even in Turner, they say if you have been treating for growth hormone for 4 or 5 years, at 12 years you start treatment. So this is a good, ideally this is how it should happen.
So what are the preparations that right now available? One is testosterone depot that is easily available, an injectable form. Number two is long-acting testosterone depot injection that is 1000 milligram, but not recommended in cases of pubertal induction for children. A testosterone gel is present and some oral preparations of testosterone are there. I'll talk about some other preparations that there are also present here. So the long-acting testosterone undeconate that is right now available, but not used in cases of pubertal induction because they have a increased risk of increased bone age that will ultimately cause a truncating final height. So that is not preferred in case of children. Rest others have been used in different studies for the pubertal induction.
So you can use it as a follow-on once things have stabilized. Yeah.
So these are all the preparation at the list, but not go details into the list.
So pretty much if you can say one thing, which one will you prefer for pubertal induction?
I'll prefer the intramuscular testosterone.
So that is very clear, because if you take oral or if you take gel, the time it takes for maturity to happen will be much longer. So testosterone is something which is going to be better in that it will have a predictable result, it will have a good result and timely result. There is one more therapeutic option which is now available for CDGP.
It's aromatase inhibitors.
Yes. So how does it work?
It will actually, it is an aromatase inhibitor. So there will be no estrogen production. So it will bone age, the fusion of the bone age will be delayed.
So how will it trigger puberty? You're treating puberty, not the height.
So testosterone will be there. It will be not converted to estrogen. The testo will act on the SDHT.
So he's not producing testosterone, na? How will it trigger production of testosterone? It is aromatase inhibitor, it is decreasing estrogen, and you said obese children have more estrogen, they have low?
It's a low testosterone, that is why.
Why low testosterone?
Because they inhibit the gonadotropin.
So this will stop the inhibition of the gonadotropin, your gonadotropins will go up. So your primary problem in CDGP is low gonadotropin. So it will stimulate that. Will it work for HH as well? Why? So gonadotropin is not there, so it is not going to work. So CDGP, that option could be considered. Many people say it's the best option, but I would say time tested is testosterone, so don't get too much confused at the moment. And let's wait for the results to come. No. So aromatase inhibitor you give for anybody with self-limited puberty. Estrogen is low, your LHFSH will go up, your testo will go up. This is the mechanism that they're trying. And TV will increase.
So, CDGP child is not obese. In that
so it doesn't matter obesity. CDGP is not having gonadotropin. You are increasing gonadotropin here. Na? Even if he is obese, doesn't matter.
We are inhibiting aromatase.
Yeah.
So testo is already not there. So estrogen will not be there.
Estrogen is there coming from a lot of places. Boys don't have estrogen at all.
No, they will have, but in CDGP they will have estrogen.
Yes, everybody has estrogen, and that's why it's suppressing your. So you are basically removing that inhibition of estrogen on the gonadotropin. This is the mechanism, and what they postulate is that this is increasing your testicular size. You are making the testis make testosterone, while there you are giving from outside. So we had the full journal club. You were not there, huh? We had the full journal club discussion on that, but I have issues on that. But this is one strategy which can be considered.
So moving on to the plan that we have planned for. So the child was already 17 years. So we planned for the testosterone injection in this child. We don't consider for the reversibility as we have seen in these cases. And we have started on the testosterone 50 milligram or lower dose IM monthly injection. But after 3 doses given, the boy showed a reversibility. Testicular volume enlarges a bit and there is some growing of the pubic hair.
So this is something which can often be tricky. Normally, we say if it's permanent HH, it should not increase. But here there is some increase. So what does it suggest about his diagnosis?
It is the CDGP and HH, if we consider, it is like a spectrum-like thing. So on one hand, CDGP has everything, 100%. One HH complete, there is no 0%. So probably patient is between somewhere.
And he is mild. Because he doesn't have that much micropenis. So he's giving you a clue that I don't have a complete deficiency. So he may have some production. So what I would postulate is that suppose you need, there are 100 GNRH neurons. They have to migrate from the placode to the hypothalamic area. You may have 10 and you may have some pubertal onset. So he may be in the 5, 7, less amount of neurons have transmitted and they are doing some work. But this will not be able to sustain the puberty. I've seen many children who have some testicular volume increase and then they stop. They don't have the capability further. Carry on.
So
So the logical step here would be
we
to do it.
stop the treatment and see for whether there is pubertal progression further or not, but the child didn't progress, so the stalled puberty. So
So what will be the role of genetics in this scenario?
if we consider from the treatment purpose or management purpose, there will not be much important in this scenario. But if we have to go for a particular diagnosis or
So,
other associations,
at the moment for let's say growth hormone deficiency or for GnRH deficiency, there are no routine recommendations. For DSD we do in everybody. Here it is not going to help much because treatment is the same. Carry on. So that you will know on clinical, and so these are all very small number of studies, and all genes can behave like that. It's a very confusing scenario. What's the inheritance usually? Most common inheritance of
it's a oligogenic inheritance.
so many genes are supporting the thing. So you can have a lot of confusing pictures. So I would not routinely go for genetics unless it's a research scenario.
So let's see what the guidelines have said that they recommend all the boys who have received the pubertal induction should be have a structured endocrine assessment at baseline and at follow-up. So it will be on the basis of the effect of the treatment. We are giving some treatment and what is its effect, seeing on the pubertal status, the anthropometry and the skeletal maturation of the child, and also the adverse effect of testosterone, like any local reaction. Is there any gynecomastia that is increasing? Is there any hematocrit increase more than 50% or not? Or other features like any behavioral changes, irritability in the present in the child. So further treatment, we started again the children on the 100 milligram of testosterone injection. And this time, after regression of the gynecomastia for a bit, the patient again developed gynecomastia. So we thought that whether this is a testosterone-induced gynecomastia in that scenario. Then we slowly increase the dose for every 6 months. And presently the patient is on 1000 milligram international unit dose, 3 monthly dosing. His current SMR staging is 3 ml with PVKR of 5 and SPL of 7 centimeters.
Theoretically, this could be a case of giving aromatase inhibitor along with testosterone because that can take care of the gynecomastia parts. Although studies have shown that aromatase inhibitors are inferior to tamoxifen when you treat that. But if you look at the whole picture, okay, I want the height to grow for more time, testosterone is also there, you can think of aromatase inhibitors in a plus minus fashion. If you're giving testosterone with aromatase inhibitors, you are also giving an anabolic agent for the bones. So probably the bone effects will also be less. So this could be something which can be thought of in that perspective. So now we have gradually built it up over 2 to 3 years to 250 milligrams. And if you look at the last report, it shows that his testosterone levels are plateauing off. So at around 3 weeks, his testosterone is only 100. So that's why the graph that you showed, we need to probably shift now to the 1000 milligram preparation. How do you shift to that?
We can first we can give a 0 dose, give a 6-week dose and 12-week dose, then every 3 months.
So you have to give a loading dose as well in that regard. Yeah, carry on.
So what the guidelines have said that we should potentially monitor for the potential risk of gynecomastia during our treatment, and it is due to the imbalance between the androgen and estrogen level in our body, and they said we should assess and reverse the gynecomastia by adjusting the dose. If we can't reverse them, there are medical management that Sarah had already explained about blocking the estrogen effect on the breast like clomiphene, tamoxifen or aloxafen, administering androgens like danazol or DST.
So this guideline is both for hypo and hyper.
Both for hypo and hyper.
So this problem is very rare in hypo. It's mainly there for the hyper one. There also in the worst Klinefelter cases also, once you go to 250 monthly or 3 weekly, you will expect the breast to come down. At the initial phase, it may worsen.
And they had also mentioned that after medical treatment, if it is after 3 months it is not responding, then we can go for the mastectomy or liposuction in the surgical management. So not only the pubertal induction, we should also consider for 17 years for the further future fertility options. And in that scenario, we have some GnRH infusion we can give, but that is not usually available. So we can choose for the HMG and HCG preparation both to induce the sperms by 6 months and pregnancy by 12 months. The poor responder or the good responder in this scenario would be if the testicular volume is large in the initial phase, if there is inhibin B is higher in the initial phase, and there is a pubertal, the child is
increase in testicular volume is the best sign that they are going to improve. Now, this is something you have to be very, very careful about. We have had problems like suppose somebody got married and they say, I want to go for fertility, and you immediately switch them from testosterone to HCG. Now, till that time, they were getting a direct supply. Now, their testis has to produce. So, it is not going to happen overnight. It's going to take few months. So, when you look at testosterone, you look at after 8 weeks or so. So, the problem would be that if they start HCG right after pregnancy, there would be a lot of issues in terms of erectile dysfunction and the problem. So, we say, okay, you treat for at least 1 year. Once things are stabilized, then you can plan to do that. Otherwise, all that social issues we have seen can happen.
So I don't know whether these medications are available in India or not, but there are some testicular patches, both testicular scrotal region in the and as well as non-genital skin. There are some nasal preparations also available and some pellets. The major benefit of having this pellet is the adherence. You don't have to change it like in every 3 months or that, but there are some complications.
It's like long-acting depot. It was very commonly used in Melbourne. Dr. Margaret Zachary used it a lot. So it's like an implant sort of a thing. You give it and it's there for 3 months or so.
Yes.
Yeah. So that is there like a long-acting. But now Deconate is good. The Deconate, the problem is that you have to, what is the volume of Deconate?
4 ml, sir.
Yes, you have to give 4 ml is not 1000. I think you have to give 2 injections together.
Yes, we have to give.
So it's a big one. So you have to give in 2 different glutes. So that's it. So that is the issue which is there. But otherwise they are happy. They get a much better response. So pellet is even more. They have to do suture and everything. So it is undeconate. They are also shifting to that. So that's a better preparation than that. And then nasal and all, of course, with a sort of a steroid hormone and all those things, you have to be cautious about. How much is going to absorb, how much is going to reach the target tissues and everything. So the best, of course, I am always there is for the injection. The oral tablets may be an option in rare scenarios where somebody doesn't want to go for injections, but then the response may be variable. The hepatotoxicity with the earlier oral ones was more, it's less now. Dr. Syed Farooq Ali is asking 17-year-old boy with nephrotic syndrome since 2 years of age, intermittent relapse remission, was on steroid therapy, delayed puberty. How do you manage this case? So this, of course, is a steroid-induced toxicity. Will decide about how short is the child. There is a role of growth hormone therapy in somebody who is on a long-term steroid therapy, and how much is the bone age. If we are able to take off steroids, that will be the best thing, and they may improve over time. And then depending upon the bone age and height, we can start with a pubertal induction, maybe wait and watch because often we see a good response there. But if the steroids are being continued in that scenario, we will have to be a bit cautious from that perspective. Dr. Randa is asking, could a male have abnormal height like 150 and he's 13 in few months, but testicular volume of 3 to 4? Yes, it can happen because he hasn't really entered puberty. So when you say a testicular volume of 4 ml, we're talking about start of testosterone production. The height increase will happen only once somebody is around 10 ml and more. So this is something, this is just a start. It's not causing the height stimulation. Dr. Asma is asking SCG used for pubertal induction. I think that's an important point. And one point which we did not discuss was that there are European research which is coming up in terms of using the LH and FSH. So when you say HCG, HMG, HCG is basically LH, HMG is FSH. That is the actual form. So recombinant LH and recombinant FSH is the recommended one, but it's very, very expensive. So we use HCG and HMG as a reasonable cost. Even that cost is a bit significant. There are studies from Europe who have used FSH and LH for induction at mini puberty stage. So if you identify somebody at mini puberty, they are giving it. Japanese guidelines talk about continuous gonadotropin therapy right from 12 years of age. And similarly, as Dr. Alapan was saying, you can use HCG as a good agent. The point here is that how long are you going to give it? What is your basic purpose? So if cost and injections are not an issue, the cost in India would be like 10,000 rupees for a combination of LH, FSH in a month. And you have to give at least 8 injections a month. So this is going to be the burden. If somebody is agreeing to that, that's the ideal physiological therapy. It will increase your testicular volume. It will increase your penile size. It will be associated with curling of pubic hair. So all those things will be done with a gonadotropin therapy. But the cost and the number of injections that is going to be there is something which is a bit of a hindrance from that perspective. And of course, you start with both HMG and HCG, because if you just give HCG, that can be harmful because the intratesticular testosterone levels will go up really high, and that may damage the germ cells which are not protected by the Sertoli cells. If you give them HMG or FSH before, their Sertoli cells will become bigger, they will protect the germ cells, and you will have much less difficulty. Dr. Candy is asking for children with MPHG secondocranio. Is it advised to induce puberty? For how long? Yes, definitely. So many of our patients with craniopharyngioma would require testosterone or gonadotropin, and there is no contraindication at all. So growth hormone we wait for 1 year since the stabilization. For this you don't need to wait. This is a very, very clear scenario. You need to treat them from that perspective. And there's no confusion about that. You have to treat, and they have become fertile also. I have people who had craniopharyngioma surgery who have fathered child also. So this is something that is a very good response from that perspective.